So we have Dr. Jonathan Bean. He's a professor of physical medicine and rehabilitation at Harvard Medical School. Dr. Bean and his team archived the Boston Rehabilitative Impairment Study of the Elderly, or Boston RISE, into ADEP in 2018, and more recently submitted an extension to Boston RISE, which is currently being curated by our staff right now. So that should be released in the next month or two. We've also featured Boston RISE in a webinar that took place in October called Accessing and Using Two Disability Rehabilitation Studies for Secondary Analysis, and that's available on the ADEP website if you're interested in that.
I'm going to be talking about what's called the Boston RISE study. This was a longitudinal cohort study. I want to acknowledge Alan Jetty and his group, who were important collaborators on that project. And that was an NIH-funded longitudinal cohort study. It was funded primarily through an R01, and then also was extended through a K24 award as well. So the basic premise of the work that led to this study, the work that we do, is on preventing mobility-related problems that lead to disability. Primarily because those are the first problems that tend to occur as someone gets older and they're sort of going down the path of functional loss. And so it really gets to this issue here. So if you look at this image here on the right, and I'm supposed to stay by the microphone so I can't wander, but pardon me, on the left, it actually says 54 seconds. And this was a woman, this is in Coolidge Corner in Brookline, Massachusetts. There's a high population of older adults that live in this community. And so she was looking at the light. It took her 6 seconds to realize that the light had changed. Then she started walking, and by the time you see on the right panel she gets across the street, there's about 15 seconds left. It took her about 46 seconds to cross the street. So the year after I took this photograph, they reduced the time down to 35 seconds. So effectively, she's disabled, right? In fact, I was walking here in Galveston. I crossed Broadway. It's actually 20 seconds to cross Broadway. So, you know, Texas, everyone drives. No one walks. But at any rate, in Boston, a lot of people have to walk. And if she has to get to the pharmacy, all of a sudden she's got a real problem, right? She's going to go back to her primary care physician and say, can I please have that pill that helps me with my mobility skills? And no such pill exists. And at the time, and still is, the main treatment is physical therapy. So the issues are if I took her and I lined up 5 different physical therapists, and I asked them to prioritize the attributes that were really driving her mobility decline, I would probably get 6 different opinions about which attributes to prioritize. And so the challenge for us in rehabilitation was recognizing from a laundry list in the literature of about a dozen different attributes that were all identified as being very important to mobility skills in older adults, what is the sort of subset that really are driving decline? And so we had done a number of clinical trials, and we decided that we needed to go back and do a cohort study to really get at these issues. And so this was, at least for the aim 1 of our study, we looked at cross-sectional data, and we sort of categorized these different attributes. We called them rehabilitative impairments, attributes that when deficient or impaired are targeted in rehab care. And we looked at their association with mobility activities, and then actually through aim 2 and 3, we looked at mobility decline over time and the onset of disability, or really poor functional status at the end of 2 years longitudinally. And then, as I said, we actually did an extension of the study. We got funding where we looked at the primary outcome, which was a questionnaire, the late life function and disability instrument, and we evaluated that 2 additional years and continued quarterly phone calls. But I'll get to that in a minute. So the first aim was at baseline, we'll identify the rehabilitative impairments that are associated with current mobility limitation. Aim 2, we look at the rehab impairments that predict decline in mobility over 2 years. And aim 3 was which rehab impairments present at baseline predict progression of disability over 2 years, or really what we looked at was poor mobility status because there are different trajectories of change over time. Our recruitment, this was not a population-based study, but what we did do is we took we recruited from a 10-mile radius in Boston, which actually is a lot of people because Boston is a sort of small, tightly compact city. And we used the census data to sort of guide the ethnic and racial distribution of the people we recruited based on age. And actually, there's one error in this slide in the sense that, which I'll get to in a minute, but we looked for people that were 65 years and older that could speak English. I said lived within a 10-mile radius. We wanted to have 50% that were under 70, between 65 and 75, 50% that were older. We were 2/3 female, and actually it was 80% white and 20% non-white. That was the typo. The way people were assessed is that they were evaluated in 2 assessments, one that was done at our Spaulding Rehabilitation Hospital Outpatient Center, which was based in Cambridge, and also at Mass General Hospital, involved two study visits that occurred annually. And then we also had quarterly phone calls every 3 months. The main data set, as was mentioned, is the first 2 years of follow-up, where we have demographics, we have health history, we have physical exam, cognitive testing. We have detailed medication use using the Iowa, and I'm forgetting the acronym, but the Iowa algorithm for categorizing medications. We had patient-reported function, performance-based function, measures of pain and depression and other aspects of mood, self-efficacy. We had measurement of falls, rehabilitative care history, and physical activity. So it's a pretty rich data set. I'm using the past tense because I'm saying when we collected it, it's the current tense because it's still out there and exists. The quarterly phone calls addressed falls and follow-up of rehabilitative care, episodes of rehab care. The falls were self-reported over the previous 3 months. We also recorded hospitalizations, emergency room visits, rehabilitative care, as I said. And then we also tracked the reason that people missed visits or not. And so that's something that can be recorded as well. It can be obtained. The second round of archiving includes our extension data. So it's year 3 and 4. It includes the patient-reported functional measures, the quarterly fall visits, the visit tracking. And then also, as part of our cohort study and being an active lab where we had postdocs and the like, we had a number of ancillary studies and also some that were initiated by collaborators. We have Kathy Schmidt in the room, and part of her doctoral work, she was looking at spinal stenosis. So we actually have imaging among a subset of patients of spine imaging, looking at and actually operationally defined spinal stenosis amongst those individuals. We also had another ancillary study where CT scans were obtained of the spine and of the thigh, and actually we have the ability to, within that subset, look at muscle mass, look at muscle quality in those areas as well. The other thing that we did was that, as with any longitudinal cohort study of older adults, you're going to have missing data, especially when you're dealing with performance-based measures. What I can say is that Boston Rise rivals some of the strongest cohort studies out there in terms of having a small level of missingness, but nevertheless, we still had to do multiple imputations in order to fill in missing data for some of our analyses. And so that's also available, the imputed data sets, not only at baseline, but also longitudinally. So as part of the presentation, we were asked to address certain questions. And the first one was, why did we decide to archive our data? Why would anyone put themselves through this level of abuse, if that's not really the right term, but this extra effort? Well, one is that it's a federally funded mandate. And so when it really was emphasized at the time that we received our R01 that they really wanted data sets to be archived. And I think that all of us involved with our study felt like that was an actual important cause to embrace. That's really critical, especially since what made our study unique was the sort of diverse measures of neuromuscular impairments that didn't exist in the literature, and we want people to take advantage of that. We don't presume that we're going to come up with every question that can be addressed. I'm going to highlight a little later on some innovative questions that were highlighted by some of the junior investigators that have worked with this data set and addressing different questions. So that's a very important thing in order to advance the field of rehabilitation science. And so we really viewed that as paramount importance. So what are the benefits of working with a repository like ICPSR? And that question was asked before, and I can't emphasize enough the support and the benefit of working with them, especially along the lines of data curation. That should not be, Amy shouldn't underemphasize that. I want to reinforce that point. They're really, really helpful with that. And part of it is that, whenever you have a study and you have your data, you sort of consider it your baby and you want to see it go out in the world and live on its own 2 feet and earn a living and all those kinds of things. And so the thing, they really, really helped with that, because there's no way that we were prepared to think about all these sorts of issues and how we needed to prepare the data accordingly. And also, I should just say that the whole fact that we were connected and had the ability to do that was through funding by this institution, by this program. So again, as well, that's really, really critical. And so I know that as the grant is sunsetting, there's sort of challenges in thinking about that. But those sorts of that access to that pilot funding was critical. The other point is that at that time, as NIH was embracing this, they went to their default funding mechanisms and said, well, you can apply for an R03 or an R21 to archive this data. And, so you're thinking about going through that whole process, and then you get reviewers from outside the field of rehabilitation science who may criticize the value of this field. Is it really a contribution? Or you get other people that may, we've all been through it. And so it's not a really quick and efficient mechanism for getting funding in a timely way to seize upon the staffing that you have at that time to make that transition. And this sort of funding, which went through a peer review process, decision process, was very helpful because it was expedited. And I think that I sort of highlighted a lot of the points there in terms of a lot of the benefits. And we'll have a moment to ask if people have questions about that. So some of the lessons learned and tips. The data curation process, for all of us that were involved with the project, even though we were really hyper-vigilant about how we collected our data and making sure that everything was objectively done and consistent across the study, it was very helpful to really reinforce those points. And to have a well-written SOP is really critical, standard operating procedures, to ensure that the data is clean and well-organized, and to maintain strong and consistent supervision of data management. I think that in retrospect, when we started our study, we weren't anticipating that we were going to be doing data archiving. We were just so focused on getting the project going and getting it done. But if you can plan ahead and think about that ahead of time, that's really important, because usually grants are funded not specifically for carrying out the grant and then archiving it, and so you may need key staff to stick around that know the data that can help do that, and we were able to do that. I want to acknowledge Rachel Ward, who really shepherded this process through and made all the difference. Without her, I don't think we would have been able to pull it off. And so that's really a critical piece. And the other thing to think about and to be aware of is that if you do have ancillary studies of your project, it's very important to maintain the integrity of those studies and to maintain the coding that people use to define the variables that they use for that ancillary study, and to be able to include that in your standard operating procedures, because that's a really critical piece as well. And if summary variables are actually created, to hang on to those as well, because that'll save people time in the field. So some quick examples of reusing data. Leanne Quach is a junior investigator that works with us in the VA, and her doctoral work was in social engagement, and so she was very interested in our data set. And initially with the original data, she did a study where she looked at the impact of social engagement on the association between mild cognitive impairment and mobility skills, and mobility decline is her interest, and also falls. And so she looked at, you could substitute, the SPPB is a physical performance measure that's in our study, but also she looked at self-reported falls at the time. This is all baseline data. And what she saw was that social engagement, levels of social engagement that people had in their lives actually mediated that association among people with mild cognitive impairment, and the fact that it was protective. And so that's very intriguing, and so she's going to be looking at that longitudinally, and this is just an example of the sorts of questions that can be addressed. And we have Eric Rosine with us here. Eric is very interested in pain, and so he did analysis where you look at pain phenotype, be it single-site pain, multi-site pain, or what's defined as widespread pain, and looking at it at risk for slow walking speed, and slow walking speed being a factor that's a problem in and of itself, as I showed you before, but it's also predictive of every adverse health outcome that we think about for older adults. And what you see is that those with multi-site and widespread pain have a much greater odds of ending up having slow walking speed. And so he's also going to be looking at that longitudinally as well. And even though there's a little typo in the percentages here, the important take-home message is that if you're thinking about the woman crossing the street, in general, older adults have multi-site pain or widespread pain, and pain's highly prevalent among them. So over a third of our cohort manifested musculoskeletal pain, over 2/3 manifest those higher levels of pain. And anyway, so that just sort of highlights some of the work that can be done with this. I will also say that we've had a clinical trial that was published in the Archives of Physical Medicine and Rehab, where we actually did a pseudo-randomized controlled trial where we had another group that was recruited identically to the people in the cohort, and they received an intervention, and we used the cohort as actually our control group. And so that was a very powerful way to begin to look at a telehealth rehab intervention and its impact on outcomes at 1 year. And so those are kind of the opportunities that exist with a data set like this, and I'll leave it open to any questions or comments. Thank you.